Feliciy and I'm here to talk about a substance-related and addictive disorder. The substance-related and addictive disorders comprises of 10 separate classes of drugs. They are alcohol, caffeine, cannabis, hallucinogen, inhalants, opioids, stimulants, and tobacco and some other unknown substances. They are divided into two subgroups, that is substance use disorder and substance-induced disorder. Substance use disorder is a cluster of cognitive, behavioral, and physiological symptoms indicating that the individuals continue using the drug in spite of already having some substance-related problem. The diagnosis of a substance use disorder can be applied to all 10 classes except for caffeine. An important characteristic of a substance use disorder is an underlying change in the brain that may persist beyond detoxification, particularly in individuals with severe disorder. Substance-induced disorder includes of intoxication, withdrawal, and other substance medication and induced or mental disorders. The essential features is the development of a reversible substance-specific syndrome due to the recent ingestions of a substance. The clinically significant problematic behavioral or physiological changes associated with intoxications are attributed to the physiological effects of the substance on the central nervous system. They are developed during or shortly after the use of a substance. Some of the factors that contribute to the abuse of alcohol and drugs are genetic predispositions to addictions or abuse, history of mental illness, neglect or childhood trauma, poor social skills or lack of social support, and peer pressures or the belief that drug abuse is not a bad thing.
Hi, my name is Raheemat and I'm going to be talking about alcohol-related disorders. So alcohol is any drink containing ethanol or a mixture of ethanol and water, usually 95% ethanol. While ethanol is the intoxicating agent in liquors, that is alcohol. Intoxicating means something that affects, there's a large amount in the body and affects the body and the mind, so people can't really think well or behave normally. Under this alcohol-related disorder, we have three main disorders: alcohol use disorder, alcohol intoxication, and alcohol withdrawal. So the first disorder is alcohol use disorder. It is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the 11 symptoms mentioned in the DSM-5 and occurs within a period of 12 months. From the name alcohol use disorder, you can note that the patients usually have a problem with the use of alcohol. It's either they're taking it too frequently or they're taking it too much, large amounts in a small period of time. Some of the symptoms that these people should experience are a craving or a strong desire or urge to use alcohol. Alcohol will be taken in large amounts or longer periods than intended. A persistent desire or unsuccessful efforts to cut down or control alcohol use. Most times these people know that they have a problem and they try to cut down on it, but it's very hard for them to cut down on the alcohol use. They have also recurrent alcohol use in situations in which it is physically hazardous. Tolerance is defined as a situation whereby your body becomes used to a particular substance or drug and then you need increased amount of that substance to achieve that effect. So people with alcohol use disorder, they usually have tolerance to alcohol and then they need increased amount of alcohol to actually achieve that effect or that desire that they want. They also will manifest withdrawal symptoms, and withdrawal symptoms are a group of symptoms that are being expressed by patients when they stop or reduce their intake of a particular substance or drug. The prevalence of this particular disorder is greater among adult men and lesser among adult women. So risk factors: environmental. The first risk factor is the environmental risk factor. Cultural attitudes towards drinking and intoxication, the availability of alcohol, acquired personal experiences with alcohol, stress level, and per substance use. Most times, if you are in an environment where alcohol is cheap and very easy to get, it can lead to an alcohol use disorder because it will be very easy to get the alcohol. And then you have the genetic and physiological risk factors. It really runs in families, and if you have maybe a father or a mother that was an alcoholic, you are prone or you're at risk to be an alcoholic. So treatment of this disorder includes detox and withdrawal. This is actually a program that runs about from 2 to 7 days, whereby these patients are taken in an inpatient care house and they are being treated and then given some things for their withdrawal symptoms in case they should relapse. And then there are psychological counseling and oral medications. There is a particular drug used to treat alcohol use disorder. There is actually no drug specific to treat this disorder, but it's something that depends, it's subjective, it depends on you stopping it yourself. But there are things we can use to reduce the withdrawal symptoms. That naltrexone is an oral medication that is given to these people to reduce their withdrawal symptoms. And then there's the injected form of that medicine known as Vivitrol. It actually helps to also reduce, it works the same way naltrexone works, so they all help to reduce the withdrawal symptoms. And then the next disorder is the alcohol intoxication. Alcohol intoxication, more commonly known in Australia as binge drinking. From the name, it means these people have a large amount of alcohol in their body and is affecting both their mind and their attitude and body. Okay, symptoms includes recent ingestion of alcohol, slurred speech, incoordination, unsteady gaits, nystagmus, that's the uncontrollable movement of the eyes, impairment in attention and memory. Most alcoholics usually will have a problem in remembering where they were or what happened during their time as they were drinking the alcohol. And then in worst cases, they could have stupor or coma. What are the risk factors for alcohol intoxication? Temperamental is still almost the same thing as alcohol use disorder. The temperamental here will be episode of alcohol intoxication increased with personality characteristic of sensation seeking and impulsivity. We can see this mostly in people that just want to have fun, and then they go to a place where they can have fun and there's a lot of alcohol, and eventually they get intoxicated by the substance. And then there are also the environmental risk factors. The treatments for this disorder, no specific treatment can reverse the effects of alcohol intoxication. Intoxicated people often receive IV fluids for dehydration. Alcohol is a diuretic, that means it works as a diuretic in the body. It tries to eliminate water from the body. And alcohol is a diuretic and increases urine output, and B complex vitamins for dehydration and to prevent delirium, and as precaution or treatment for vitamin deficiency. In severe cases such as the stupor or coma, the person should be intubated to support respiration, which may stop spontaneously, and to protect lining lungs from filling with vomit and secretions. And then the last disorder under this category is the alcohol withdrawal. From the name, you know that there is a cessation or a reduction in the use of alcohol, and then it's producing different symptoms that affects them both physically and mentally. Includes a set of symptoms that occur following a cessation or reduction in alcohol use after a period of excessive use. They must have 2 or more of the following symptoms: autonomic hyperactivity, increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile or auditory hallucination, psychomotor agitation, and anxiety. Normally, alcohol is under the class of drug we call as psychoactive. Psychoactive drugs are majorly 3. We have the depressants, the stimulants, and the hallucinogens. Alcohol is a depressant, but from these symptoms, it seems like it's acting opposite. It seems like it's being a stimulant. But the reason is this: because most times when we take in alcohol, our body gets used to having alcohol in the system, and then it tries to work harder to make the brain to be more active. So even if it gets used to that particular scenario, so once there's a reduction in alcohol, your body is still used to that brain being in a keyed up state. So when there's a withdrawal, your brain is still in that keyed up state and is giving you so many stimulating effects like increased hand tremor, agitation, and autonomic hyperactivity. For prevalence, it is estimated that approximately 50% of middle-class, highly functional individuals with alcohol use disorder have experienced a full alcohol withdrawal symptom. For this treatment, they need a quiet place, soft lighting, a positive and supportive atmosphere. Also, healthy foods and lots of fluids, because alcohol is a diuretic, acts as a diuretic in the body. And if your blood pressure, pulse, or body temperature rises, or if you have more serious symptoms like seizures and hallucinations, your doctor could suggest inpatient care and drug treatment. Common medications such as benzodiazepines are used to help treat symptoms like anxiety, insomnia, and seizures. Okay. So because of this, doesn't mean we shouldn't use alcohol or we shouldn't take alcohol. We all know that sometimes we use alcohol to be relaxed and maybe enjoy time with others. But if you can avoid it, it's actually beneficial to avoid it. But if you must drink it, you need to know what your body can take and what your body cannot take. So how much alcohol is safe is actually dependent on your gender, on your body size, and genetic factors. For example, women absorb more alcohol from each drink than do men and tend to be more susceptible to alcohol-related liver damage. The Canadian Liver Foundation supports the level of alcohol consumption proposed in the Canadian Law Risk Alcohol Drinking Guidelines, and it is 10 standard drinks a week for women with no more than 2 drinks a day, 50 standard drinks a week for men with no more than 3 drinks a day. It is the amount of alcohol present in a drink that matters, not the type of drink. So some people might drink 5 bottles of Smirnoff and take 1 shot of all these liquors. It might actually be the same thing, because we're not actually looking at a particular drink, we're looking at the amount of ethanol present, because that is the intoxicating substance. And from research, it is known that your body treats alcohol like a poison, because after digestion, every substance after digestion goes straight to your liver for detoxification. So once alcohol goes to your liver for detoxification, it produces a substance known as acetaldehyde. Acetaldehyde is very poisonous to the body. It can affect the liver, it can affect the stomach lining. So your body can handle some amount of acetaldehyde, but it cannot handle a large amount of acetaldehyde. So when it's too much in the body, it causes all these effects I've mentioned. So knowing your gender, knowing your weight size, and knowing genetic factors would help you know the amount of alcohol you should take, and also the type of alcohol you are taking.
Caffeine withdrawal symptoms. Example, consumption of 20 mg by an individual who typically consume 300 mg. Prevalence rate. More than 85% of the adults and children in the United States regularly consume caffeine. In attempt to be permanently stop caffeine use, more than 70% of the individual may be experienced at least once. Caffeine withdrawal symptoms. 47% may experience headache and 24% may experience headache plus 1 or more symptoms as functional impairment due to the withdrawal. Development and course. Symptoms usually begin at 12 to 24 hours after the last caffeine dose, at peak after 1 to 2 days of abstinence. Caffeine withdrawal symptoms last for 2 to 9 days with the possibility of withdrawal headache occurring up to 21 days. The symptom usually reemit rapidly within 30 to 60 minutes after re-ingestion of caffeine. Treatment. Take pain relievers like ibuprofen, acetaminophen, aspirin and naproxen. Drink plenty of water. Avoid meditation, beverages and foods with added caffeine, and have an adequate sleep. Features and characteristics. Prolonged daily use of caffeine, headache, marked fatigue or drowsiness, dysphoric mood, depressed mood or irritability, difficulty concentrating, flu-like symptoms, nausea, vomiting, muscle pain and stiffness. Diagnostic criteria. Recent consumption of caffeine, usually in excess of 250 mg, example more than 2 to 3 cups of coffee. The signs of symptoms are not associated with the psychological effect of another medical condition. Example, migraine, viral illness, and are not better explained by another mental disorder, including intoxicity or withdrawal from the another substance. Cultural related diagnostic criteria. Habitual caffeine consumers who fast of religious reason may be increased risk of caffeine withdrawal. Causes. The different type of causes of the caffeine withdrawals are osteoporosis. Osteoporosis easily breakdown of bones, restless leg syndrome, leg pain, irritable bowel syndrome, the fibrostic breast condition, the premature ventricular contraction, the fibromyalgia. Risk factor. Temperamental. Heavy caffeine use have been observed among the individual will have mental disorders, including eating disorders, smoker, prisoners, drug abusers, alcohol abusers. Thus, these individuals could be higher risk for caffeine withdrawal, the acute caffeine abstinence, and the environmental. The unavailability of caffeine is an environmental risk risk factor for incipient withdrawal symptom. While caffeine is legal and used widely available, there are conditions in which caffeine use may restricted, such as during the medical procedures, pregnancy, hospitalization, religious use, um, during travel and wartime, and research participation. Genetic and physiological factors. Genetic factors appear to be increased vulnerability to caffeine withdrawal, but no specific gene has been identified. Cause modifiers. Caffeine withdrawal symptom usually rarely within 30 to 60 minutes of re-exposure to the caffeine. Doses of caffeine significantly will increase. Less than one useful daily dose may be sufficient to prevent alternate caffeine withdrawal symptoms. Example, consumption of 20 mg by an individual who typically consume 300 mg. Prevalence rate. More than 85% of the adults and children in the United States regularly consume caffeine in an attempt to be permanently stop caffeine use. More than 70% of the individual may be experienced at least once. Caffeine withdrawal symptoms. 47% may experience headache and 24% may experience headache plus one or more symptoms as functional impairment due to the withdrawal. Development and course. Symptoms usually begin at 12 to 24 hours after the last caffeine dose, at peak after 1 to 2 days of abstinence. Caffeine withdrawal symptoms last for 2 to 9 days with the possibility of withdrawal headaches occurring up to 21 days. The symptom usually reemit rapidly within 30 to 60 minutes after re-ingestion of caffeine. Treatment. Take pain relievers like ibuprofen, acetaminophen, aspirin and naproxen. Drink plenty of water. Avoid meditation, beverages and foods with added caffeine, and have an adequate sleep.
Cannabis use disorder. Now we are going to see diagnostic criteria. It is if it is taken over long period for large amount, it may have effect on the person. Mostly they have a strong desire and craving to take cannabis. For those who use cannabis, they are mostly lacked in their recreational activities. It may also result in their they may also lack to fulfill their major roles. Most probably psychological problems are caused. Now we are going to see diagnostic feature. Cannabis use disorder related disorder includes problems because of the intake of cannabis or some related kinds of chemicals. They are mostly taken in the variety of forms like pipes, cigarettes, water pipes, and most probably with papers. Affected individual may use it over several period of days or months. Associated uses. Associated individuals may use it daily or several days or for several months. Now we are going to see associated features. Individuals who regularly use cannabis often report that it is being used to cope up with their stress or some of their disorders. They may get relaxation while they are saying that they may get relaxation when they are using that. Some cannabis users are motivated to minimize their users. It is very much important to aware. It is much important to make an aware over the users. Now the risk and prognostic features. Most likely the prevalence and severity of cannabis withdrawal are greater among the heavier cannabis users, and particularly among those who seeking treatment for cannabis use disorder. Nowadays the awareness has been created. Among the beginners and those who are taking treatment for this cannabis. Withdrawal severity also appears to be positively related to severity of comorbid symptoms of mental disorders. Mental disorders are also being caused because of this. Now development and course. The amount, duration and frequency of cannabis smoking that is required to produce an associated withdrawal disorder quite attempted or unknown. Basically that amount, duration and frequency are not known among the users. So they are taking in a improper amount that may cause the disorder. Most symptoms have the onset of 24 to 72 hours, and it may get at peak for even for a week. It may last more than 30 days.
Hallucinogen use disorder. They include fencyclidine use disorder. And here the main characteristic features includes fencyclidine, example like PCP, which is also known as the angel dust, and less potent but similarly active compounds such as ketamine, cyclohexamine, and diaclopin. They produce feelings of separations from mind and body, hence dissociative. In low doses and at high doses, stupor and coma can result. These substances are most commonly smoked or taken orally, but they may also be snorted or injected. The main causes is there's little information about the cause for fencyclidine, but among individuals admitted to substance abuse treatment, the cause are those for whom fencyclidine was the primary substances were younger than those admitted for other substances use. They had lower education level and were more likely to be located in the west and northeast regions of the United States compared with other admission. For the prevalence rates of fencyclidine use disorder is unknown, but approximately 2.5% of the population reports having ever used fencyclidine. The proportions of users increase with age from 0.3 of 12 to 17 years old to 1.3 of 18 to 25 years old. 2.9 of those ages between 26 years and older reporting ever used fencyclidine. There appears to have an increase among 12th grade graders in both ever use to 2.3 and from 1.8, and past year use to 1.3 from 1.0 of fencyclidine. Past year use of ketamine appears relatively stable among 12th graders. The mode of treatment. The effective for fencyclidine dependence is unknown due to lack of randomized, controlled clinical trials. Once the patient is through the initial phase of detoxification, then psychiatric and addiction care is indicated. Depending on the ongoing severity of the symptoms, the patient may be required transfer to the psychiatric unit if the psychosis is not yet under adequate control. The severity and duration, they include of three severity. The mild severe, which is presence of 2 to 3 symptoms, the moderate presence of 4 to 5 symptoms, and the severe, which presence of 6 or more symptoms. Fencyclidine intoxication. The characteristic features of fencyclidine intoxications reflects the clinically significant behavioral changes that occur shortly after ingestions of the substance or a pharmacologically similar substance. The most common clinical presentations of fencyclidine intoxications include disorientation, confusion without hallucination or delusion, a catatonic-like syndrome, and coma of various severity. The intoxication typically lasts for several hours, but depending on the type of clinical presentation and whether other drugs besides fencyclidines were consumed, may last for several days or longer. The most common methods of ingestions are eating and smoking marijuana or tobacco in which liquid has been sprayed. It accommodates in body fat, and flashback can occur as it is released from fat during exercise. The severity and duration. In individuals who use fencyclidine less often than those with dependence, the maladaptive patterns of fencyclidine use may lead to clinically insignificant impairment or distress as manifested by at least one of the following occurring within a 1-year period. Recurrent use resulting in repeated failures to fulfill major role occupation at school, work, or home. The prevalence rate of fencyclidine-related disorder. The use of fencyclidine or related substances may be taken as an estimate of the prevalence of intoxication. Approximately 2.5% of the population report having ever used fencyclidine. Among high school students, 2.3% of 12th graders report ever used fencyclidine, with 57% having used in the past 12 months. This represents an increase from prior to 2011. Past year use of ketamine, which is assessed separately from other substances, has remained stable over time, with over 1.7% of 12th graders reporting use. The mode of treatment. People experiences PCP intoxications or delirium often hurt themselves or others. They are generally kept in an environment where there is as little stimulation as possible. They are restrained only as much as is necessary to keep them from hurting themselves or other until the level of PCP in the body is patient. In cases, can be reduced. And antipsychotic medication may be used to calm patient of PCP delirium. There are no quick ways to rid of the body of PCP. If the PCP has been eaten, stomach's pumping or feeding activated charcoal may help keep the drugs from being absorbed into the bloodstream. Physical symptoms such as high body temperature are treated as needed. Hallucinogen persisting perception disorder. The main characteristic features of this is the re-experiences when the individual is sober of the perceptual disturbances that were experienced while the individual was intoxicated with the hallucinogen. The symptoms may include any perceptual disturbances, but visual disturbance need to be predominant. Hallucinogen persisting perception disorder occurs primarily after LSD or lysergic acid diethylamine, but not exclusively. There doesn't appear to be a strong correlation between hallucinogen persisting perception disorder and the numbers of occasions of hallucinogen use. Hallucinogen persistent perception disorder may be triggered by use of other substances like cannabis or alcohol or in adaptation to that environment. There's a little evidence regarding the risk factors for hallucinogen persistent perception disorder, although genetic factors have been suggested as a possible explanation underlying the susceptibility to LSD effects in this condition. The prevalence estimates of hallucinogen persisting perception disorder are unknown. Initial prevalence estimated of the disorder among individuals who use hallucinogen is approximately 4.2%. The mode of treatment. Some people don't need treatment. In a matter of weeks or months, the symptoms may disappear. Some anecdotal research suggests certain medicines may be beneficial, but those studies are limited. Anti-seizures and epilepsy medicines like clonazepam or clonopin and lamotrigine or lamictal are sometimes prescribed. However, what works for one person may not work for the other.
About inhalants and opioid disorder. So the features and the characteristics in this disorder is inhalant use disorder is the continued use of inhalants. This is due to continuous use of inhalants. For an example, if you're using if an example a paint worker, a petrol bunk worker using fuel, paints and other volatile compounds, the distress or impairment is caused of this. Typically, it includes a strong desire to take the drug. Difficulties in controlling its use is persisting in its use despite harmful consequences. A higher priority given to the drug use than to other activities and obligations, and increased tolerance. And the main cause, we are going to see about the causes. Inhalants are readily available and inexpensive. Actually, inhalants are available in even some local shops, and it is priceless. It is not to the maximum. It will be available in cheaper prices. So they are often used by children from 6 to 10 years of age, maybe 6 to 16 years, and even they are poor because the cost is very low. And factors that are associated with inhalant use include poverty, of historical childhood abuse, poor grades and dropping out of school. The latter two factors may simply be a result of inhalants use, however, rather than cause. And because of this problem, the students are addicted to this, and sometimes they will even left their school for this. The use of inhalants is highly likely to be influenced by peers. Inhalants are often used in group setting. The solitary consumption of inhalants is associated with a heavy, prolonged use. It may indicate that the person has more serious problem with these substances. So if you take the risk factors of this, temperamental, predictors of progression from nonsense of inhalants to use to inhalant. Use disorder include comportment non-inhalant substance use disorders and either conduct. So if environmental, it is divided in two factors, temperamental and environmental. So in environmental, these are widely legally available, increasing the rise of MI use. So childhood impairment or trauma, this is named trauma, is caused because of this risk factor. So with the non-use to the inhalant use disorder. So course and development. About 10% of 13 years old American children report Having used inhalants at least once, that percentage remains stable to the age of 17 years. Among these 12 to 17 years olds who use inhalant, the more used substances include glue, shoe polish, or tolerance, gasoline, or lighter fluid or spray fluids. Only 0.4% of 12 to 17 years old progresses has not used. These youths to expect multiple other problems. So the treatment. The treatments for this disease is individual therapy, group therapy, family therapy, 12-step education, relapse prevention instruction, cognitive behavioral therapy, which is started as CBT, and DBT, which is dialectical behavioral therapy, biofeedback and neurofeedback, regression in therapy. So features and characteristics. Inhalants are commonly known as any vapors or fumes which can be form of intoxicants on person who breathes them in an enclosed space. For example, if you are in a congested place where the painting was done newly, and if you go inside and just taken your breath inside, the smell will go inside. This is the toxic. If you are continuously in that track, you will really affected by this disease. And you should really go beyond therapies, family therapy, group therapy and something. So whatever is inhaled, the symptoms are very similar and include the sense of euphoria, dizziness, slow relaxes and an overall lethargic state of being. Knowing more about the symptoms and the dangers of inhalant intoxicant will make the decision about getting treatment for inhalant abuse a little easier. So causer, the major risk is hypoxia. Hypoxia is nothing but it is the lack of oxygen, which can occur due to inhaling fumes from a plastic bag. Another danger is freezing throat. This is not high blood, vertigo, diarrhea, pneumonia. These are the major diseases caused by this one. And prevalence. The prevalence was higher in young age groups. Actually in 12 to 17 years old, in that category, if you take 3.6% of people, individuals are addicted, and 1.7 individuals in 18 to 25 years old. And it is reported that 0.8% of Americans are all 12 years old users. And the treatment was, management may include the use of antiarrhythmics or beta blockers to stabilize the myocardium and avoid overstimulation by catecholamines. Symptomatics should be avoided. So considerations for other substance dependence or the process of psychiatrist or physical disorders must be made and coherent condition should be arrived. So we had seen the causes, treatment of this disorder. So thank you.
My name is Vipul and I'm here to explain you the features and the characteristics about the opioids. Opioid intoxication occurs when you take too much of the opioid drug. Your level of intoxication depends on how much of the drug you take. Opioid intoxication is a common occurrence in the United States. The consequences can be deadly. It causes opioid can cause intoxication occurs when you ingest too many opioids. Opioid intoxications can occur you accidentally overdose, mix opioid together, abuse the drug, take them without a prescription or for a long time. Risk factors. Elderly patients may forget that they already took their medicines and accidentally taken another dose separately. Medications by daily doses can help ensure that you don't take too much than the recommended amount. Treatment. An opioid overdose requirement emergency medical treatment. A nurse and the hospital or the emergency room will first measure your breath rate, your blood pressure, your heart rate, temperature. The emergency room provide many other toxicological screening to determine that overall effects of the overdose on your body.
Sedative, hypnotic, and anxiolytic related disorder. Features and characteristics. It's a problematic pattern leading to clinically significant impairment. It may be manifested by two of the following. It may be because of a recurrent use in situations in which it is physically hazardous. Important social, occupational or recreational activities are given up or reduced. craving or a strong desire to urge to use sedative, hypnotic or an anxiolytic. This disorder are often taken in large amounts or over a long period of time. This may cause because of taking it in a long amount or over a long period of time. It is also because of the strong desire to take strong desire. It may lead to the impairment in social, occupational or recreational activities. Sometimes the users may be lack in some social activities. Recurrent use in situation in which it is physically hazardous. Some situations may be physically hazardous. While using that, their persons are easily get affected. Now the 12 months prevalence are estimated to be 12-month prevalence are estimated to be 0.3% among 12 to 17 years old and 0.2% among adults. This shows that the more of the affected people belongs to the age group of 12 to 17 than the adults. Adults are less affected by this than the lower age group. The risk factors are temperamental, environmental, genetic and psychological, cause modifier. If temperamental, some basic users are affected only temporarily, and in environmental, because of the use, because of the affected person, there's the person surrounded by them are also affected. This is belongs to environmental. And genetic and psychological, their genes are affected, their body is psychologically also affected. And cause modifier, their activities are also modified in many ways. The main treatment is include family counseling. That is, their family members can give a counseling to them by saying the hazardous and loss of this loss caused due to this. And medical care, individuals may continue to take benzodiazepine medication according to physician's direction for legitimate medical indication over an extended period of time. Medical care, they may go to some clinics or some doctors to meet some doctors and get some treatment for this. The main treatment for the medication is benzodiazepine. This medicine helps in the treatment. Outpatient care. Patients with sedative hypnotic use disorder are frequently treated in outpatient setting, most probably stable and require minimal monitoring. These persons require minimal monitoring and also stable. So they are basically treated as an outpatient. And one more thing I want to say here is basically there is a recreational center for these persons who are affected. They may join them there and get counseling from official and can get cured. Now we can see the intoxication disorders later to that. Maladaptive, clinically significant maladaptive behavior or psychological changes that develop during or shortly after sedative, hypnotic or anxiolytic use. The clinical significations are behavior, as I said already, clinical signification may occur. They are also psychologically affected. The basic affections are slurred speech, incoordination, unsteady gait, and impairment in cognition. Their gait, that is their body structure or their activities are changed. Incoordination is that they are not involving in any activities, any social activities. Slurred speech, their speech usually gets slurred. Their tongues usually get slippery. The signs and symptoms are not attributable to another medical condition. These signs and symptoms cannot be cured because with other medications. They are only to be cured. They need to be minimize their use. The prevalence of sedative, hypnotic, and analytic intoxication is general. Population is unclear. The prevalence rate is unclear because there is a difference in usage among different people. Course and development. It is the course and development is also not clear among the individuals. The risk factors: amnesia, difficulty with reason. As you all know, amnesia is. I know about amnesia. The person who are affected by this are mostly affected by amnesia. They are mostly their recent memories are erased. Tolerance, psychological dependence, addiction risk factors same as for other drug of abuse. Their tolerance may get reduced. Psychological dependence may occur. and the main thing to note here is that if they are not getting this drug, they are in search of some other drugs to fulfill them. The main treatment for this is medication. It is important to medicate rapidly and in doses sufficient to suppress withdrawal symptoms. The medication is the important treatment. Some medicines are given and the doctor's advice are also taken. Here also, in this case also, they can go to the counseling at various places to get them cured. Now, withdrawal disorder. The main cause of this withdrawal disorder include increased heart rate, faster breathing, sweating, shaky hands, inability to split, anxiety, nausea, restlessness. Increased heart rate. Their heart rate may increase because of their use. The blood flow may be high. Faster breathing. As the blood flow is high, there is a significant cause of the faster breathing. They may be sweating at the unusual times. The shaky hands, they usually get shiverings at many times. Inability to sleep. The main thing to note here is their sleep is get affected. They are not capable of sleep. This may affect basically the sleep. If there is not usual sleep, they are affected. Nausea and restlessness also been caused. Risk factors. Medication. Medication. Consult with the medical professional before attempting to discontinue heavy or prolonged use of these drugs. The main thing to note here is that these persons who use this should not stop it immediately. They should stop it step by step. The amount must be reduced step by step to have a healthy life.
Okay, so the second group of disorders I'm going to be talking about is the stimulant-related disorder. Okay, so what is a stimulant? A stimulant is any substance that activates the CNS, that gives the CNS the flight or fight actions. Stimulants are also referred to psychostimulants or colloquially as uppers. So it is an overarching term that covers many drugs, including those that increase the activity of the central nervous system and the body, drugs that are pleasurable and invigorating, or drugs that have sympathiomimetic effects. Those are drugs that mimic the effects of the sympathetic nervous system. Stimulants are widely used throughout the world as prescription medicine, as well as without prescription, that's either legally or illicitly, as performance enhancing or recreational drugs. The most commonly used street drugs that fall into this category are cocaine and amphetamines. Okay, so we have different type of stimulants. We have the plant-derived stimulant, and we also have the synthetic stimulant. The plant-derived stimulants are stimulants that we get from plants, like from nature, while the synthetic stimulants are those that we synthesize in the lab. So plant-derived stimulants, we have cocaine. Cocaine is gotten from the cocoa plants in South America. Yeah. Then the synthetic, we have amphetamine, methylphenidates, methamphetamine, and MDMA, phenylephrine, and the rest. So what are the most commonly abused stimulants that people use? We have crack. Crack is a free-base form of cocaine. This type you can actually smoke it, while the normal cocaine you sniff it or inject it. And then we have ecstasy. Now ecstasy is actually that pill that they give you when you go to a club. It is usually called the love pill, and it heightens perceptions of sounds and sensations. It also heightens the perception when one touches or caresses another, and it acts as a hallucinogen, but it's actually a stimulant. And it contains the MDMA stimulant. That's another synthetic stimulant. We also have Adderall. Adderall is a mixture of amphetamine and dextroamphetamine. This drug is mostly commonly abused by students because it's a stimulant and it keeps them awake. It keeps them awake and alert. They are very alert and they can stay focused on a particular activity for a very long time. So students use this drug to stay awake and study at night. Then there's Ritalin. Ritalin acts the same way as Adderall, but Ritalin Ritalin contains methylphenidate, and while Adderall contains amphetamine and dextroamphetamine. These two drugs and other stimulants are actually used to treat narcolepsy and ADHD. We know that ADHD, we need something that keeps them focused, and for narcolepsy, we need something that will keep them awake. So stimulants, something that will stimulate the body, they are actually used for these reasons, but people abuse them and use them for other reasons. Okay, so how does stimulants work in the body? During the synapses, that's between two neurons, we have the neurotransmitter coming out from one neuron going to another neuron. So drugs like cocaine, and after the neurotransmitter goes from one neuron to another neuron, or goes to the receptor of the postsynaptic neuron, there's something we call the reuptake mechanism. It takes back those neurotransmitters back to the presynaptic neuron so that they won't stay on the postsynaptic neuron and we experience their effects. But drugs like cocaine goes and blocks the reuptake system, and then this drug keeps staying in the synaptic cleft and also the receptors of the postsynaptic system, and then it keeps stimulating the body. So these people have stimulated senses and everything. And then drugs like amphetamine, cocaine and amphetamine are really abused, so those are the ones we concentrate on. Drugs like amphetamine, they also block the reuptake system, and they also increase the amount of neurotransmitters coming from the presynaptic neuron to the postsynaptic neuron. The neurotransmitter we're talking about here is actually dopamine, because dopamine has so many effects as well as the stimulating effect. So this amphetamine blocks the reuptake system as well as increase the amount of dopamine that's coming from the presynaptic neuron. And most people people say amphetamine, the effect of amphetamine is more because it lasts more and it has two ways it actually creates this effect. But the effect of cocaine usually will last for 1 hour or less. So the effect of cocaine is not as high as the effect of amphetamine, but they are both widely abused drugs. Okay, so there are three main disorders in the stimulants related disorders. We have the stimulant use disorder. From the name, we know that these people actually have a problem with the use of the stimulants. It's either they take it too frequently, or they take it too much, or they are dependent on that stimulant. Now, you have to, according to the DSM, you have to have 2 or more of the 11 symptoms listed in the DSM, and also it must be occurring for at least a period of 12 months. Some of the symptoms include the stimulant is actually taken in large amounts or over a long period, and then there are unsuccessful efforts to cut down, as well as tolerance and withdrawal. And they also spend time in activities necessary to obtain the stimulant. For instance, if I know that I can only get Adderall or ecstasy rather in the club, I would be going to the club at least 3 times a week just to get that stimulant. And then we have the stimulant intoxication. Intoxication being a large amount of the substance in your body, causing a physiological as well as a psychological effect. So the DSM states about 7 or 9 symptoms, and out of those symptoms, the patient must exhibit at least 2 of the symptoms for the person to actually be stated that he or she has this disorder. So things like tachycardia or bradycardia, increased blood pressure or decreased blood pressure, pupillary dilation, evidence of weight loss, which is very, very, very common in people that take stimulants. If you see their before and after pictures, there's usually a significant decrease in weight. And then there's psychomotor agitation or retardation, and then in worst cases, confusion, seizures, or coma. And then the last one is the stimulant withdrawal. Stimulant withdrawal, it means they are cutting down on their stimulants, or they are totally stopping it, and then this causes a group of symptoms. In stimulant withdrawal, they will usually have a dysphoric mood as well as a physiological function, like insomnia or hypersomnia, increased appetite, and so many other symptoms listed in the DSM. For prevalence, amphetamine type stimulants in the US, 0.2 among 12 to 17 year old, and 0.2 among individuals 18 years old and older. Rates are similar among adults, males and females, but among 12 to 17 olds, the rate of female is greater than that of males. For cocaine type stimulants, also is the same rate, but the rates are higher among males than females. And then for Adderall type stimulants, a study was actually conducted among college students, and they found out that A full-time college student between the age of 8 and 22 is twice as likely to abuse Adderall than those of the same age and are not in college. Under the risk factors for this disorder, we have family history of drug addiction, the wrong crowd. When you move with the wrong people, when you are friends with wrong or bad influence, you get introduced to these stimulants and these drugs, and you take them. There's anxiety and depression and loneliness, especially for females. We use this to cure anxiety or our loneliness or a stressful life event that's just occurred in order to take our mind out of that particular event. And then having another mental disorder and being an athlete. Most times we hear of athletes abusing these stimulants in order to send enough blood to their limbs and their peripherals so that they can be better at what they do. So some athletes actually abuse stimulants and use stimulants, and it's a huge risk factor of being addicted to a particular stimulant. And for treatments, we have the detoxification and medically managed withdrawal. Then there's drug rehab. This treatment includes medication for depression or other disorders, counseling by experts, and sharing of experience with other addicts. And then we have the chemical dependency detoxification program. So it's a program that helps people that are dependent on stimulants. So in this program, they tend to help people with their withdrawal symptoms, because basically if you're trying to cut down on this stimulant, you're going to have a withdrawal symptom or withdrawal symptoms. So these people help them with their withdrawal symptoms, and they give them drugs like Suboxone. This Suboxone helps to reduce the withdrawal symptoms, as well as methadone. They also help to reduce the withdrawal symptoms. And then we have the self-help groups. The self-help groups help people who are addicted to drugs. And the self-help support group message is that addiction is a chronic disorder with a danger of relapse. Self-help support group can decrease the sense of shame and isolation that can lead to relapse. And also prayer. Well, there's nothing religion or having God by your side cannot cure. So prayer is also a treatment for this disorder.
Now I will be presenting under tobacco-related disorder. This includes of tobacco use disorders. First, tobacco use. The main characteristic features of tobacco use disorder is that it is common among the individuals who use cigarettes and smokeless tobacco daily, and is uncommon among individuals who do not use tobacco daily or who use nicotine medications. Many individuals with tobacco use disorder use tobacco to relieve or to avoid withdrawal symptoms. The large majority report craving when they do not smoke for several hours. Spending excessive time using tobacco can be exemplified by chain smoking, that is, smoking one cigarette after another with no time between cigarettes. Because tobacco sources are readily and legally available, and because nicotine intoxication is very rare, spending a great deal of time attempting to produce tobacco or recovering from its effect is uncommon. Giving up important social, occupational, or recreational activities can occur when an individual forces an activity because it occurs in tobacco use restricted areas. Use of tobacco rarely results in failures to fulfill major roles obligation, but persistent social or interpersonal problems occurs as an intermediate prevalence. The causes of tobacco use disorder include some temperamental, which individuals externalizing personality traits are more likely to initiate tobacco use. Children with attention deficits or hyperactivity disorder or conduct disorders, and adults with depressive, bipolar, anxiety, personality, psychotic, or other substance use disorders are at high risk of starting and continuing tobacco use or tobacco use disorder. From the environmental factors, individuals with low incomes and low educational levels are more likely to initiate tobacco use and are less likely to stop. Genetic and physiological factors contribute to the onset of tobacco use. The continuations of tobacco use and the development of tobacco use disorder with a degree of heritability equivalent to that observed with other substance use disorder, that is about 50%. Some of the risk is specific to tobacco and some is common with the vulnerability to developing any substance use disorder. The prevalence. Cigarettes are the most common used tobacco product, representing over 90% of tobacco or nicotine use. In the United States, 57% of adults have never been smokers, 22% are former smokers, and 21% are current smokers. The prevalence of smokeless use tobacco is less than 5% and the prevalence of tobacco use in pipes and cigars is less than the actual use of tobacco. The 12-month prevalence of DSM nicotine dependence in the United States is 13% among individuals aged 18 years and older. For the male and female prevalence, the rates are similar among adult males and females, which is nearly 12 to 14%, and decline in age from 17% among 18 to 29 years old to 4% among individuals aged 65 and older than 1. And 65 and older is 1%. The 12-month prevalence of DSM-4 is nicotine. In many developing nations, the prevalence of smoking is much greater in males than in females, but this is not the case in developed nations. In many developing nations, the prevalence of smoking is much greater in male than in female. For the severity and duration, specific current severity, mild, presence of 2 to 3 symptoms, moderate, presence of 4 to 5 symptoms, and severe, presence of 6 or more symptoms. The mode of treatment for tobacco use disorder includes of psychotherapy, psychoeducation, support and education, and pharmacotherapy. For tobacco withdrawal, the main characteristic features is the symptoms impair the ability to stop tobacco use. The symptoms after abstinence from tobacco are in large part due to nicotine deprivation. Symptoms are much more intense among individuals who smoke cigarettes or use smokeless tobacco than among those who use nicotine medication. This difference in symptoms intensity is likely due to the more rapid onset and higher levels of nicotine and cigarette use. Tobacco withdrawal is common among daily tobacco users who stop or reduce, but can also occur among non-daily users. The heart rate decreases by 5 to 12 beats per minute in the first few days after stopping smoking, and weight increases an average of 4 to 7 lb or 2 to 3 kg over the first year after stopping smoking. Tobacco withdrawal contributes clinically significant mood changes and functional impairment. The causes of tobacco withdrawals include temperamental, where smokers with depressive disorders, bipolar disorders, anxiety disorder, and attention deficits or hyperactivity disorder, and other substance use disorder have more severe withdrawal. Genetic and physiological includes of the genotype which can influence the probability of withdrawal upon abstinence. Prevalence: approximately 50% of tobacco users who quit for 2 or more days will have symptoms that meet criteria for tobacco withdrawal. The most common endocrine signs and symptoms are anxiety, irritability, and difficulty concentrating. The least common endocrine symptoms are depression and insomnia. The mode of treatment: tobacco use disorder is considered highly treatable when the appropriate pharmacological, behavioral, and psychosocial interventions are used. Treatment may include education about the nature and health consequences of tobacco addiction, individuals and group addiction support programs, relapse prevention counseling, and separate tailored treatment for those with lower and higher motivations to quit. Any of the numbers of FDA-approved medication may also be used to treat withdrawals of tobacco. Severity and duration: tobacco withdrawal usually begins within 24 hours of stopping or cutting down of tobacco use. Peaks at 2 to 3 days after abstinence and last 2 to 3 weeks. Tobacco withdrawal symptoms can occur among adolescent tobacco users even prior to daily tobacco use. Prolonged symptoms beyond 1 month are uncommon.